Everybody, I am Dr. Vineet Sankhla. I am an interventional cardiologist working at SIMS Hospital. And today we'll discuss about COVID-19 and heart. As you all know, we are right now in the middle of this pandemic. And you must have heard, you must have read also that COVID-19 has higher morbidity and mortality in the patients who have pre-existing heart disease and pre-existing heart problems like hypertension, diabetes. So the morbidity and mortality is much higher in such patients. So we discuss about all these things. Now, one of the proposed mechanism is that the COVID-19, the coronavirus, basically binds to ACE enzyme 2, the angiotensin-converting enzyme 2. Now, ACE2 is actually widely expressed in heart and lungs. Lot of presence of ACE2 in heart and lungs, and that is why the coronavirus basically attacks the heart and lungs, and it causes a very serious disease. Now, ACE2 has protective roles against heart failure, myocardial infarction, hypertension, lung disease, and diabetes. Now, if you see this figure, we all know that angiotensin is converted into angiotensin 1. Angiotensin 1 is converted into angiotensin 2, and the enzyme is ACE1, which converts angiotensin 1 to angiotensin. We have all read this in our medical school days, the ACE1, which converts angiotensin 1 to angiotensin 2. Angiotensin 2 basically is vasoconstrictive, and we know that angiotensin, we know that ACE inhibitors will inhibit this enzyme, ACE1. And angiotensin 2 acts on the tissues by AT1 receptors, and this is blocked by the ARBs. Now, angiotensin 2 is actually converted into some of the molecules by ACE2 enzymes. Now, this enzyme we have actually not read before, and this is the ACE2 enzyme. It's not the ACE1 enzyme, it's the ACE2 enzymes, which converts angiotensin 2 to some of the molecules which are actually useful in the body. They cause vasodilation, they are antifibrotic, they are anti-apoptotic, they are anti-proliferative, and they actually have a protective role. Now, coronavirus will basically will enter into the body by attaching to this ACE2 enzymes. And as I told you before, the ACE2 enzymes is actually present in heart and lungs. So once it attaches to this ACE2 enzymes, it causes loss of function of this enzyme. So naturally, anybody having corona infection will result into loss of ACE2 enzymes function, which will result into all these problems and loss of protective effect of ACE2 enzymes. Now, if that comes to one more controversy, that giving ACE inhibitors in the patients with COVID will actually lead to detrimental effect. The reason is because once we give ACE inhibitors, what will happen is that it will inhibit this ACE1 enzymes, and it will lead to overexpression of this ACE2. And overexpression of ACE2 means more coronavirus can attach to this ACE2 enzymes. And that is the reason it was proposed that giving ACE inhibitors will increase the morbidity and mortality in the patients with COVID infection. But that has not been proved actually. It is not seen in, it may be seen in vitro, but it is not seen in vivo. And in fact, I'll come to the future slides where all the leading societies have come up with a consensus statement that ACE inhibitors should be continued in the patients with COVID infections, and they should not be stopped actually. Now, the virus which causes COVID-19, COVID means coronavirus disease 2019, because it was first introduced, it was first seen in 2019. Now the virus which causes is called as SARS-CoV-2 virus. It is similar to SARS-CoV virus, coronavirus, which actually came in 2003. But the difference between this SARS coronavirus 2003 and the present 2019 virus is that the COVID-19 virus or the coronavirus 2 actually binds to ACE inhibitor much stronger than the original SARS virus. And that is the reason that higher binding capacity, higher binding affinity of coronavirus 2 may be why it is more pathogenic than SARS original virus. Just because it attaches to coronavirus 2, just because it attaches to the ACE enzymes, ACE2 enzymes much more strongly, that's why it affects heart and lungs much more with more affinity as compared to the original SARS virus. Now, as I told you, ACE2 is protective in heart failure, myocardial infarction, And just because the coronavirus attaches to ACE2, it causes loss of this function. And this is the reason that COVID-19 binding may be the reason that patients with heart disease, diabetes, and hypertension are at greater risk of death. While this has been seen in vitro, but it has not been proven in vivo that ACE inhibitors should not be given in the patients with COVID-19 infection. In fact, most of the societies have come up with a statement that we should not stop ACE inhibitors and we should continue ACE inhibitors because sometimes, because we know that ACE inhibitors can be useful in certain disease like heart failure and post-myocardial infarction, LV dysfunction. So ACE inhibitors should be continued. They shouldn't be stopped in the patients with COVID-19. Now, other mechanism where COVID-19 can cause cardiovascular complications is by systemic inflammation. As we all know, it causes systemic inflammation all over the body. It causes septic shock, sepsis, and sepsis can affect the heart. It can cause direct myocardial injury. As I told you, ACE2 is present on heart and lungs. It affects the lungs, so naturally there will be hypoxemia, and this can lead to a decreased oxygen supply, which can lead to a myocardial dysfunction. It can lead to an acute coronary event. The MI which occurs is type 2 MI. Type 2 MI means there is no coronary artery atherosclerotic block seen. Basically, it is a coronary event with a normal coronary artery. It's a type 2 MI. And sometimes even certain therapies can result into a cardiac dysfunction. Like if you give antiviral therapy, they can have cardiac toxicity. Same way, chloroquine or hydroxychloroquine can result into QTC prolongation, and that can result into arrhythmia problems and a cardiac toxicity. So these are proposed mechanism where COVID-19 can affect heart and can cause cardiovascular complications. Now, the case fatality rate in any patients with comorbidities, if it is a cardiovascular comorbidity, then the case fatality rate is almost 5 to 10 times much more than a patient who is not having any cardiovascular comorbidities. Well, if you have any questions regarding my presentation, you can put it in the chat box, and after my presentation, we can discuss about questions. So let me complete the full presentation, and then we can take on some questions and we can discuss about COVID-19 infections and particularly cardiovascular disease. So the case fatality rate is almost 5 to 10 times higher when there is an associated comorbidity of cardiovascular disease. Diabetes, chronic respiratory disease, smoker, hypertension, all these are again comorbidities where the morbidity and mortality is much higher in these kind of patients. So these are the top targets of coronavirus. Men, we know that men is much more a risk factor as compared to women or small children. In fact, now they are proposing that it could be that the virus is actually getting attached to testicles, and testicles are supposed to be one of the etiological or one of the causative factors seen in coronavirus, which is having increased mortality in men. Seniors, as I told you, advanced age more than 60 or 65 is much more higher risk factors for serious coronavirus infection. Smokers again is a risk factor because already they have some lung problems, and this can result into a significant serious critical disease. So patients with pre-existing cardiovascular disease have higher morbidity and mortality, almost 5 to 10 times higher. And the manifestations are basically myocarditis. The cardiovascular manifestations are myocarditis, cardiac dysfunction, LV dysfunction, acute LV dysfunction, myocardial infarction, mostly with normal coronary arteries, and any patients who presents with elevated troponin levels, BNP levels, D-dimer, these kind of patients are very, very high risk. So anybody with mild to moderate disease, you can always do the test of troponins, BNP levels, you can do D-dimer, and such kind of patients usually fare worse as compared to the patients who are showing no elevations or little elevations of troponin. Well, as I told you, certain complications of certain medicines also can result into cardiac toxicity, like QTC prolongation with chloroquine. Anybody with any patient presenting to you in your clinic, in OPDs, in outpatient clinics, you should always suspect COVID-19. And what are the risk factors and clinical and radiological risk factors for a patient that he may be having COVID-19 is fever. The fever is the most common complication. Fever and cough and shortness of breath. These are the very common symptoms of COVID-19. So anybody having fever, but we know that patients may not have fever. Certain asymptomatic patients are also there, but fever is mostly the likely presentation if the patient is symptomatic. Of course, cough, shortness of breath, any flu-like symptoms in a healthcare worker. Healthcare workers are supposed to be a higher risk of contamination, higher risk of getting infection from the patients. Any contact with COVID-19 in last 14 days, arrival from the overseas in last 14 days, lymphocytic count, any lymphopenia is again suggestive of COVID-19 infection. And of course, if you do X-ray and if you see a bibasal pneumonia, or if you do a CT, if it shows a bibasal ground glass appearance, then again these patients are at risk of COVID-19 infection. In fact, they are high risk of COVID-19 infections. So how do you treat a STEMI patients with in the presence of this COVID-19? So anybody with presenting with the STEMI, and if the patient is COVID-19 positive, or if the patient is person under investigation. So how do you know that patient is high risk? Is by these risk factors which I've actually discussed in this previous slide, that anybody having these kind of risk factors, symptoms, signs, it is supposed to be that this patient may be suspected positive coronavirus. So anybody presenting with STEMI, and if the COVID-19 is positive, or if it is a suspected case, then you do a basic, if no such risk factors are present, and if the COVID-19 is negative, you can go ahead with primary PCI. If you suspect that this patient is having some risk factors, or if the COVID-19 is positive, then you do an echo. And if there is no RWMA, you can go ahead with medical treatment, or maybe a CT coronary angiography can be done. But if there is a regional wall motion abnormalities, and if the high risk features are there, like anterior wall MI is there, cardiogenic shock is there, life-threatening arrhythmias is there, then probably you can consider PCI, but then make sure that you are wearing PPs yourself and your cath lab staff also. Take all proper precautions. If there are no high risk features and the patient is having STEMI, like a small inferior wall MI, you can consider thrombolysis. And in case if there is a failure of thrombolysis, then again you can do a rescue PCI. So in short, only the patients with high risk cases like anterior wall MI, some kind of hemodynamic instability, these kind of patients should be actually subject to primary PCI. And anybody presenting to you with any kind of procedure, whether it's a cath procedures, operations, any kind of procedure, should be taken as suspected COVID-19 positive in the current era. And you should always ask the history, and a rapid test, which is, I don't think it's available, rapid test, but at least a test should be done in semi-urgent cases. If there's an urgent case, then you take it as COVID-19 positive and take all the precautions and save the life of the patient. What are the cath lab considerations in the presence of COVID-19 infection? So whenever possible, do a rapid care testing, which is not available in India right now, but consider the patient as positive case. In case if you don't have the history and if you don't find any positive symptoms, then consider this patient and take proper precautions with yourself and along with the cath lab staff. Minimize the number of the cath lab staffs and make sure that cleaning mechanism is done. Now, doing about the echocardiographies, T should be avoided in a COVID-19 era right now. So transesophageal infection, because the chances of aerosol generation is very high in transesophageal, because we have to open the mouth and we have to insert the probe inside. So it generates a lot of aerosols and very high risk of infections are there. So T by and large should be avoided. Even transthoracic echocardiography should be limited for 15 minutes. It should be done better at the bedside. Patient should not be shifted to the echo room, because again, if the patient is positive and shifted to the echo room, he can infect so many persons there in the echo room, including the technical staff and other patients also. Exercise ECGs, the treadmill test and the stress echo should again be, by and large, should be avoided unless it's very, very necessary, and they should be avoided in the current era of COVID-19. CPAP, BiPAP again should be avoided, because these are again high aerosol generating procedures. Now there's a lot of discussion going on about COVID-19 causing thrombotic complications, and it is seen that majority of the patients who succumb to COVID-19 have developed some thrombosis or thromboembolic disease. And in fact, there are recommendations coming that anybody certain risk factors like acute illness, moderate to severe disease, bedridden status, diarrhea, sepsis, liver injury, all these patients are very high risk for of thrombotic complications, especially the patients who are having lymphopenia. And what are the thrombotic complications? They develop pulmonary microthrombi. Many patients have developed pulmonary embolism also, DIC, and so these are the complications of thrombotic complications: DIC, MI, pulmonary venous thromboembolism. And sicker the patient, the higher the risk of venous thromboembolysis. And there's a recommendation that anybody from mild to anybody from moderate COVID disease should be given a VT prophylaxis. I mean, they should be given a prophylactic anticoagulation right from the moderate disease. Means don't wait, don't prove that these patients are having a venous thromboembolysis. Start with anticoagulation prophylaxis right from the moderate COVID disease. You can start with LMWH. Oral anticoagulations are not advised. Heparin, plain heparin is not advised. It's basically LMWH which is advised as a venous thromboembolism. So anybody, in fact, some of the guidelines are telling that anybody admitted with COVID disease, which may not be possible in India because we are admitting every asymptomatic patient also with COVID, but any sick patients admitted with COVID, like anybody beyond moderate COVID-19, moderate disease should be at least on prophylactic anticoagulation. These regarding medications, we should not stop NSAIDs or paracetamols. I don't think they cause any problems. They are not they are not harmful. It's a myth that they are harmful. ACE inhibitors should not be stopped. In fact, we should give ACE inhibitors in patients with heart disease if they really require. LV dysfunction patients have to be on ACE inhibitors. If we stop ACE inhibitors in LV dysfunction, it will be detrimental. Chloroquine, well, it's still not proven. ICMR actually suggested chloroquine should be given for the healthcare workers or who are directly involved in corona patients, but I don't think any patients who are having mild disease or general public should take chloroquine. It should be restricted to the healthcare workers. Still, we don't have a definite clinical trial showing its efficacy. Plus, there is a concern about toxicity developing with chloroquine, like increased QTC. So, I don't think, unless it's a very direct frontline worker involved in treating the coronavirus patient directly, then probably he can take chloroquine. Or if there's a sicker patient with COVID-19, then as a compassionate therapy, we can give chloroquine, but it should not be a blanket therapy for every patient who is high risk for COVID or probably who is suffering from COVID-19 infection. Other experimental strategies like antiviral, anti-inflammatory, convalescent sera. We know that convalescent plasma, which has been taken from a patient who has already recovered from the COVID-19. Well, these are all experimental therapies. They can be tried, they can be given. Nothing has been proved. Same comes with antiviral therapies, remdesivir and lopinavir, and all other therapies are still, the research is going on. And we don't know what will happen, and we don't know exactly which will be the perfect treatment for COVID-19. There are a lot of articles coming as amiodarone as a possible therapy for coronavirus infection. Again, it is still not proven, and there are certain mechanisms where amiodarone actually prevents the entry of the virus, but I don't think it's proven. I don't think currently I will be prescribing amiodarone for the treatment of COVID-19 infection. Statins, so patients should be continued with blood pressure medications and heart failure medication. They should not be stopped. And one more thing is the statins. Statins also should not be stopped. They should be continued in a COVID-19 infection, unless the patient is having acute liver injury, where probably statins, you may decrease the dose or stop it so that it may not cause an acute liver injury precipitation. So this is about the COVID-19 and the heart. So we are still evolving regarding as far as therapy is concerned, and coming days will tell us exactly what therapies are useful, what therapies are recommended. So a lot of research is going on. It's still evolving, and let us see how does the future unfolds regarding COVID-19. Okay, thank you very much. Stay safe, stay healthy, and I wish you a best of health. And wish you best of health to you and your family. Take care. Thank you.